Thank you for coming down, Barry.
My pleasure.
It's great to have visiting firemen around.
Where's the fire?
So tell me why you're here, at least theoretically, and how that has changed.
I was here to give a talk at the law school on what the status of patient rights under the Affordable Care Act, which is what the Republicans call Obamacare, and I call the Patient Protection and Affordable Care Act. And what happened was the law school lost a colleague unexpectedly, and they scheduled the funeral during my talk, and the funeral was more important than my talk, which is rightfully as it should be. So,
Well, we have you now, and we can talk to you about it. Only this week, my organization with another one had a luncheon program which we called "How Healthy is Healthcare in Hawaii," where we touched to some degree on, may I call it Obamacare?
Sure.
Went out with
It's easier.
I went out with an email to that effect, and one guy called me up and said, "You can't call it Obamacare. How dare you do that?"
why was he objecting?
Well, I think he's a big Democrat.
Yeah. Well,
He considered it pejorative.
it's intended to be pejorative by the Republicans. That's why I prefer the Affordable Care Act, because that was the point of it. Although whether it's affordable is another question.
Well, I'm, it's really perfect that you're here and that we can talk about this because I've made a number of tapes, with leaders of the health community here, the healthcare community, and so I'll put this tape in with those. It'll be really a valuable piece. So can you tell us in 7 million words or less?
Watch out what you ask for.
What is this act about?
Well, the thing that people forget, because it's hard to explain, and I think Obama has not done a perfect job of clarifying the act, is that it's in 10 parts. And some of the parts are relatively minor. It involves Indian health care and public health issues that aren't politically hot enough for anybody to fight over. The core of the act has one important feature, and then a second one that's almost as important, and that is it regulates private insurance. And the Republicans will say this, that it federalizes private insurance, but I wouldn't disagree with them. It takes the private insurance market where you can deny people coverage for pre-existing conditions. You can do all kinds of sometimes dirty stuff, as insurance companies sometimes are inclined to, and it makes all of it unacceptable and illegal. And so there can be no pre-existing conditions, and you can't exclude people from coverage, and you have to offer fair premiums. It moves insurance back from this individual model to a community rating model where everybody's covered, and you can distribute the cost across the population you're insuring. So it makes insurance, in theory, fairer, and you spread the cost more evenly. That's the biggest piece of it.
Can I stop you there?
Yep.
Just put a hold right there. It strikes me that is contrary to the way insurance has developed in other areas in this country and in the world. You have underwriting,
Right.
and if somebody is a greater risk, you charge them more. If he's a lesser risk, you charge him less.
That's what you do with homeowners insurance and casualty insurance and so on. But there are all kinds of controls on that, including just the sheer number of subscribers, making it easier to police. Healthcare has been prone, I think, to the predations of some providers and some insurers in particular. Not all, but some. You're trying to make money. And in fact, historically, health insurance started with the Blue Cross Blue Shield plans, and they were all community rated. They were nonprofit corporations. They weren't publicly traded companies. And their goal was to provide care for a large community, and they weren't going to risk rate each subscriber. Once you start risk rating, you and I each have enough problems that we're going to pay highly variable premiums, and we can't afford it. Too many people can't afford it.
So it went off the nonprofit model, and it got to be profit, and it got to be really, really big business.
Right after World War II, it started to rapidly turn into driving the blues into a competitive quandary where they had to, in some cases, divest themselves of their model and become competitive.
So I mean, the market required them to go that way in order to survive financially.
Probably, that's probably right. The private for-profits were taking away clients from them because they would, as is still the case today, the companies would try to insure younger populations who never got sick, and you can make money on that. You just try to avoid people like you and I, because we're getting at the point of being expensive.
We're a real burden.
We're going to be a burden, hopefully in our 90s only.
Yeah.
But
Well, but it gets worse and worse. I mean, if you don't mind, I really like to study the history of it.
Sure.
So, but the government did not see this coming down the pike. The government could have regulated it back then and made it into a community kind of model then, but it didn't do that.
it didn't do it because private insurance has always been regulated by the states. So each state has an insurance commissioner. All insurance isn't just health insurance is regulated by these commissioners. And the commissioners always had the ethic of letting the market forces work their way out. So it was very much a free market designed model with the commissioners pushing, but they didn't have much power, and they still don't have much power in many states to push back on high rates or predatory practices.
Mm-hmm.
So it's kind of minimal regulation, and it wasn't a federalized system of regulation. You know, we're a federation in effect, and the states always regulated insurance.
Retrospectively, if we had the opportunity to fly back in time to say the 50s, when it was beginning to go to the profit and competitive mode and away from the nonprofit, would it have been a good idea for the federal government to get involved and say, wait a minute, we want everybody insured, we want a community model? Wouldn't that have been a good thing?
I think it certainly would have been. And it was in the 60s when Medicare was being planned that you could see the need to start anticipating some of these issues. But we always had employment-based insurance, and it didn't matter much until really we could do more health things to make us feel better. It wasn't until the 60s and 70s we had the tools. So nobody worried much about it. There was no federal pressure to regulate this because cost inflation wasn't an issue, and medicine couldn't do very much.
It wasn't.
It didn't matter much.
You mean it couldn't technologically do that
couldn't
much?
technologically do that much.
Yeah. And then, of course, we forget how quickly we forget, even in our own lifetimes, that the expectation was less in those days. So you only lived so long. Okay, big deal.
Right.
You could only, as you say, expect a certain amount of, benefit through the existing technology, and beyond that, don't worry about
Right,
it.
and you didn't die in the hospital. My grandparents died at home. My parents died at home.
Yeah,
Didn't want to go to the hospital because it wasn't. They probably couldn't keep you alive very long anyway.
Yeah.
It was just expensive.
So then, we have a trend. We have a trend in the bulk of our lifetimes from the 1960s and 70s and 80s, where people had higher expectations because the technology was better, and the medical community relied on the technology to build itself and to get bigger and more profitable. Because if somebody were, the 60 Minutes story a year ago, I don't know if you remember, they talked about Medicaid and how it was a bottomless pit, and it was unbudgeted expenses at the rate of $10,000 a day for people in the last part of their lives who were really not competent, but whose family wanted them to stay alive, and
Right.
they didn't care about living wills and that sort of thing. So the result was, that last 10% of your life
Eats up all the
you
resources.
spend all the money.
Right.
And all these factors are working, and now we have a situation which has somehow become a train wreck. Am I right?
It's going to be a train wreck because the healthcare cost inflation is huge. I think we're spending 17% of our gross domestic product on healthcare. It'll be at 20% in 4 or 5 years, 25%, 10 years. Now, straight line projections are always a mistake because things never work quite as you expect.
Right.
But and you might say, so what? If we're getting health care and it's extending our lives, we can afford to spend it, one could say.
17% is a lot of.
It's a lot of money. It's a lot of money.
So, the interesting thing is that while this all happens and we spend more and more and we extend our lives and we spend more money, in every which way on medicine, is it really an ethical issue there? It's not just the people who are all wired up. It's the notion of spending so much of our personal wealth on medicine. Is it really appropriate? Is it really necessary, or should we stop doing that? Personally, I know it's hard to stop doing that. You want to live, right?
It's an interesting question. I was just at a board meeting for an East Coast hospital system. I'm on the board of this system. It's 24 regional health systems, all under one umbrella. And one of the doctors on the board said, we have to stop being so American and demanding everything up till the end of life. Sometimes you just have to say, I don't want it anymore. Let me die, leave me alone. But he said he couldn't persuade either patients or doctors to readily buy into it because he thought, and I think he's probably right, this is not a new observation, that Americans want everything. We really have high expectations. We want the best care we can get. The British, not so much. They'll accept treatment stopping at a certain point because that's the way the culture is built. We want everything, and we want it now, and we want it till we continue.
How did we get there? I mean, after Entebbe, the Jewish organizations in Hawaii brought a doctor from Israel to speak and to tell us what happened at Entebbe. And he was on one of those C-130 planes that went in there. And the one thing that somebody asked him a question which provoked a very interesting answer, and the answer, the statement he made was, you think that Israeli doctors, or for that matter, European doctors, are like American doctors. They're not. We just work for a living. We don't walk on water. We don't expect to earn a lot of money. We just learn our trade and do our trade the best we can. We have the gratification of that. But we do not, we are not gods the way it might be in the U.S. And that's very interesting. I didn't know that, it's a new thing. And it shows you that somewhere the U.S. got into another thing and off the track of that. And we have a different view of health than anywhere in the world.
Yeah, I think we probably do, but I'm not sure it's just health. I think part of this American exceptionalism is in healthcare it manifests as wanting everything and doctors wanting to give everything to please patients. That may be, there's a larger cultural observation here that I'm not equipped to make, but I think it's real. Mm-hmm. American doctors, respond to what they think they can give, but also to what patients seem to want. I mean, there's a doctor-patient relationship. Hospitals market like crazy, and they promise our doctors are the best and we'll give you everything you need.
It's a business.
It's a culture of private markets, advertising, expectations that are elevated, and so on.
Yeah, I mean, but doctors, they spend hundreds of thousands of dollars on medical school. These days, they walk away from medical school. What did I hear in this program the other day? With 180,000 on the average of debt. In Hawaii, is actually a lot less than that for some reason, and they feel they should make as much money as anybody alive.
They're entitled to turn it back, and all that time and all that effort.
And the model, the insurance model, the way coverage is handled, encourages them to do things maybe they shouldn't necessarily do.
Oh, absolutely. I mean, the insurance model is built on the old Blue Cross model, which is usual customary fees. And I used to represent Blue Cross Blue Shield of Massachusetts. Physician panel would set fees every year, and it was based on what they were charging plus some inflationary factor. There was no control, and every insurance companies charged it, paid it when doctors demanded it. It was all a happy inflationary system, which rapidly started to scare Nixon, in the 70s, and the HMOs came in under Nixon to try to control already a crazy system, spiraling out of control. That hasn't changed much. I mean, managed care has sort of faded away, and a lot of healthcare is still paid on a fee-for-service basis. And as you say, doctors are trying to capture a target income. They like to be upper-class professionals. We all do, if we could get it.
And it strikes me that we could have, we don't quite have it now. I mean, people say that, infant mortality is higher in the U.S. than it is in other places. Longevity is less than it is in other places.
And it's deteriorating, just like it is in Russia.
Why is that? Do you have right.
Why is it? Because we don't have a coordinated system. We don't have enough primary care doctors. The minorities and the poor in inner city and rural areas don't have good access to care. So infant mortality is in part an observation of lack of access to a good nurse, to a pediatric nurse, to a clinic, and so on. And it seems to me that's part of a poorly coordinated system. I mean, central planning has its problems, but coordination would have some benefits here.
So here we have...
And the Affordable Care Act offers some of that, trying to link things up and coordinate.
Here we have an infrastructure, okay? I don't know if we have as many doctors as we want. Maybe that's another question for you. But we do have a lot of doctors, and we have a lot of medical expertise, and we have great medical schools, and we have great literature, and we have great infrastructure. And if it were, say, reorganized a little bit, remanaged a little bit, we could have the greatest health system in human history, for sure, easily. So it's just, am I right? It's just a question of insurance and management.
I don't think it's ever quite that simple.
I can try.
Nice trick. Nice trick. I mean, for example, you can make some observations, but how to make these changes is not easy. Probably we could do with a lot more nurses who are highly skilled, and not so many new doctors. I mean, the AMA will say we need a lot of new doctors, and there are 20 new medical schools starting. But frankly, good nurses will provide abundantly good care at a level of their competence that solves the problem of infant mortality and lots of issues that haunt us.
Mm-hmm.
You provide more allied health professionals, you solve some of the problems. The other things you can go for is trying to change reimbursement and trying to coordinate care so that doctors actually are connected to each other. You don't get duplication in drug dosages and duplication in prescriptions and in care. And that starts to cut the costs and maybe improve the care at the same time. So there are probably 100 different remedies, and the Affordable Care Act probably has 100 of them. It has lots of darts that are intended to be thrown at the wall to see what sticks. Demonstration projects, centers for innovation. It's actually full of innovative ideas, some of which may bomb out, some may succeed. That's a big part of the act that nobody talks about.
But that's I can see people attacking the act for that. We don't want to do this test and that, throw it on the wall innovation. We want just a hard, proven solutions.
Well, and there's a lot of money going for that. There's a lot of money for evidence-based medicine.
But the truth is, that's the way you tackle a problem like this. You have to do that.
You learn systematically what works.
Yeah.
So I think we found that, I'd heard this statistic last week at my board meeting, about 38% of what doctors do is based on evidence, and the rest of it isn't really proven to be effective, and much of it is a waste of money. It turns out we haven't really studied enough to know what interventions work, but doctors do it because they get in the habit of doing it because their peers do it. Well, surely that's a lot of waste of money.
So yeah, let's take a moment and talk about evidence-based practice, because we did a show on evidence-based practice for nurses. But I'd like to hear the model and how it works and how it can benefit us.
Well, the model is you try to systematically study using control groups, if you can do it, what a practice does. Does it really have long-term advantages? And so let me see if I can think of an example recently. I mean, we keep finding new evidence of things that don't work. The installation of defibrillators to control heartbeat. We know that they're installed way too often. Probably 40 to 50% of the defibrillators that are surgically implanted weren't necessary because they don't really give advantages. We find all the time that therapies that were thought to work turn out not to be beneficial. So if you have a cardiac problem, you always took niaspan along with Lipitor. Niaspan was supposed to raise your good cholesterol, made you potentially live longer. The latest study found that not only does it not raise the good cholesterol, but it causes higher levels of strokes. So the standard of care suddenly changed.
How did it get
Suddenly
onto the market if that's true?
Well, because there was earlier evidence from incomplete studies that suggested benefit, no evidence of big casualties, but this was a much longer term study, meaningful evidence-based study, and they discovered that in fact it wasn't very effective and had side effects that shouldn't be tolerated.
I think
so,
that underscores.
So the practice changes all the time. Medicine changes all the time, and evidence-based medicine means you're studying everything systematically all the time, and then you have to force doctors to stop doing things, and changing the culture is sometimes slow. They're in the habit, and sometimes doctors continue to practice when the evidence is very clear. It's not productive. But if they're getting paid for it, that's part of the problem that you referred to. If reimbursement doesn't catch up fast, of course they'll keep doing it until they finally are forced to stop. So part of this is how tough are the peers and the peers and the specialty societies, how tough are hospitals in managing doctors and saying, let's cut back on this procedure. We think this is not necessary anymore. Hospitals have trouble managing doctors. Doctors can be arrogant. They have to be sometimes to be confident in dealing with patients. And they're a hard group to shepherd around.
What's the role of the insurance company in all this? The insurance company says, you want the insurance company to pay for both of these drugs. I shouldn't do that as a matter of the studies, the most recent studies. It's not indicated, so I'm not going to pay for the second drug.
They can do that. They have formularies set up, and what they might do is simply charge you more. So the patient has to bear the brunt of this. Now, the formulary can also control the doctor's access, so some drugs are going to be off the table if the evidence starts to pile up.
So, but just to deal with the insurance decision making. So here's this insurance company, hugely powerful because of that.
Yeah, yeah.
And they make a medical decision based on that study.
Well, they have a medical director who is
Who's a
typically a
doctor,
conscientious
presumably.
doctor who looks
Yeah.
at the evidence and thinks systematically about it and tries to impose some rationality. And he's presumably not so driven by the numbers as the actuaries in the company. He's trying to develop a standard of good medicine that's frugal good medicine. That would be the insurance company model. If you don't push frugal too hard, that's fine.
Yeah, they still want to make a profit.
They do.
I did a little segue. I remember in the movie Sicko, Michael Moore's
Right,
movie.
right.
There was a really chilling thing about how, whenever any effort was made in Congress to reform health care, there were certain doctors, or rather certain congressmen who were lobbied, to resist the reform. And then their terms would expire, and then they would get these multi-million-dollar jobs.
Right, right.
It was really a payoff, and I know that Michael Moore was not always accurate, but hey, that sounded pretty accurate to me.
Right.
So, I mean, it corrupted the thing right at the
Well,
root of it.
Because healthcare is such a big industry, I mean, it's so tempting to go from Congress into a lobbying position. And there are lots of good lobbying positions. They pay much better than Congress.
Yeah, yeah.
Now, there's no doubt there's this level of corruption's a strong word, but it really corrupts the judgment of politicians because they're being lured by the seduction of a really wonderful job after they finish their political life.
Yeah.
It does distort their judgment.
The other thing you mentioned, which I think is really worth taking a look at, is this notion of the study. In the past, in the 50s, the 60s, even the 70s, studies were small. Studies
Right.
were more random. It was a sample. But with the advent of modern database technology, you can make a study that really has legs on it.
Right.
That includes hundreds of thousands, millions, who knows how many people, and you can really get a handle on the human race. So as you say, maybe the FDA might have approved it on the basis of a small study back when. Our experience since then, is much more
Right.
profound. And so what we have is a changing way to look at these things that, of course, doctors will resist because they were taught in the early days, and
Right.
and now we have much better information coming. But it seems to me that the advent of HIPAA some years ago, the whole notion of keeping data secret, and a lot of doctors, I think, at least, and they do in this town, they resist that sort of thing. They don't like to give up their data. And we don't have nearly as much database analysis as we should.
Probably not. I think what's going to happen, though, with the advent of electronic medical records coming on fast and furious, because there's so much federal money to subsidize hospitals adopting this. My system just spent $400 million adopting a system-wide electronic medical record system after a lot of study, and they introduced it as if you were launching a military operation, everybody holding everybody's hand. And the government, I think, is reimbursing 150 million of it. Still a chunk of change. But the idea is you suddenly have an integrated look at everybody's record. You can do your own mini studies within your hospital system of your certain population groups and so on. So it's a good start. It's a piece of data mining.
Yeah.
And I find hospitals now are data mining relentlessly, looking for something going wrong that you can't quite detect. One doctor has an infection problem that he didn't even know.
Yeah.
You spot it, you fix it.
Yeah.
That's potential to fix a lot of adverse events in hospitals,
Yeah.
at least.
This could be nirvana when we try to
Could be.
actually do it right.
If it's done right, it'll be a big improvement.
Yeah.
And then the evidence-based piece of it, I mean, we've had the Framingham study going on forever with, I don't know how many people it is, 100-some thousand people, the nurses' studies in England. And we have lots of groups that we were studying for decades. And the evidence keeps coming in. Lipitor works, something else doesn't. We're learning more and more, and medicine has to adapt faster and faster, I think.
But it gives you a more accurate view. I mean, years ago, for example, in cancer, somebody would have a database, and so that the doctor would talk to the patient. He'd say, "Well, if you take this combination of therapies, your survival rate is going to be, according to the studies,
Cancer was
X
always
percent."
way ahead in having
It was,
5-year
wasn't
studies.
it?
Yeah, they always had good
yeah.
studies.
They were willing to share.
Right.
I guess it's an essential element of oncology, but it should be an essential element of everything.
It should.
Every best practice, and you
Right.
can really learn from that. So, assuming that the CARE Act actually works in this way, what's going to happen in terms of the reopening of medical records?
I think the pressure will be, I mean, there's always been an exception in HIPAA for research and so on. I mean, there are exceptions to the confidentiality controls, so this will just push that harder because there are a lot more people now, researchers, chasing research grants to really open all of this up. And it's part of the evidence-based medicine drive that Congress passed before the Affordable Care Act, pumped $1 billion into evidence-based research. That's a lot of money. And I think doctors can't resist the pressure at some point. It's going to open up the process much more. Patient privacy will still be respected, I think, but their blinded studies will be much more likely.
So we'll all live longer.
Well, that's a hopeful thought. Among the other parts of the act that are worth talking about, of course, is how you get more health care to the poor who have very poor access, and that's the Medicaid expansion, which is also subject to constitutional attack now. Medicaid is now available to anybody at up to 133% of income, the average adjusted income. And that expands Medicaid tremendously. And of course, the governors are upset because they have to pay a significant part of that.
What's the constitutional attack on?
That the government is saying you have to open up Medicaid in this way, or we won't let you get Medicaid dollars at all. It's a big stick.
So it's a sanction.
It's
that they complain about.
If you don't want to play by our rules, you can't get the Medicaid money, which is billions of dollars. It's probably half of every governor's budget. And the governors are saying this has crossed the line into being coercive. This is not just a stick and a carrot. Now it's a carrot that's being used to club us. And,
beyond the constitutional powers of the
beyond
federal
the constitutional
government.
powers of the federal government to go so coercive in demanding this because it's such a lot of money that's at stake. And it's not a terrible argument. It is an argument that has superficial plausibility.
Well, you really wonder if the Republicans in attacking this are just trying to attack this president and get him out of office.
Of course.
And make him look silly.
This is all Republican ideas in the Affordable Care Act. Because Obama couldn't push through anything like what Ted Kennedy wanted, which is Medicare for all, been the dream since the 70s, universal health care. This is this patchwork of ideas that use market forces and fixing insurance and expanding Medicaid. This is nothing new. The previous generation of decent Republicans pushed a lot of this. The current generation just want to kill Obama, as far as I can tell.
Yeah, that's so
Fight
interesting.
this at any cost.
Yeah, even at the cost of the country's systems.
Indeed.
And you really wonder, what's happening in Congress. I mean, a lot of people don't like Congress for that and for the Tea Party and the thing about the debt ceiling. And it just seems that the government is dysfunctional because it can't address these things on a substantive basis.
Never has been able to. I mean, Kennedy proposed this bill for universal health care in 1970 and it went down in flames. And that was a much different political time, but still there was resistance to, then it was the scream of socialism. I still hear that scream, that to provide decent health care for everybody with some cost controls is to be socialist. I'm not sure what that means, that that's a bad thing.
It's really looking backward.
Yeah.
When Europe is doing what we should have done.
They offer care at
Canada.
significantly cheaper than we do, and they have better mortality rates and morbidity rates, generally.
So
The French love their system.
Yeah.
The Germans regulate private insurance even more harshly than Obamacare does, and they're happy with their insurance. The Swiss use private insurance that's highly regulated. They're perfectly happy with it. They all have cost problems, but our cost inflation rate is so much higher than theirs. They're in a different world.
I know there are some good things in the Obama Health Care Act. What's the proper name again?
It's the
Health Care Reform.
I have to think of this myself. It's the Affordable Care Act is the way we generally refer to it, the Patient Protection and Affordable Care Act.
So it got,
the
it
PPACA.
got mangled from what it was intended to be. It's a sort of a political potpourri of everything.
It is.
And some of the things are going to be good, clear, and clean, and some aren't. And when you shake it and bake it and look at the totality of it, maybe it's really not that good. Is this a burden or a benefit now? We're going into a very complex time.
I think it's a benefit. I mean, I think the insurance industry is hoping that this will all get resolved fast. They would rather it, I think, be held constitutional because then they at least know what the rules are. They're ready to offer all kinds of options. They won't be quite as profitable as they used to be because they can't adversely select against people with pre-existing conditions and so on, but they're turning their attention to India, other countries. They're moving into other markets where they can sell products.
American insurance companies.
Yes, they are.
Oh, how interesting.
Absolutely, in a big way, to India especially. So they're not fretting too much. They think they can live with this and make it work. And, it's a different model of heavy federal, more heavy regulation by the feds. They've set more ground rules than they've ever done before. Medicaid expansion raises a question about whether doctors will take Medicaid patients. They already don't want to. Medicaid pays 40% on the dollar. Whether this expansion makes sense, it's a compromise. It leaves doctors unwilling, probably, to take more patients. So it's a question mark.
Maybe they should call it the law of unintended consequences.
Well, we'll see. We'll see what happens, I mean, there are other pieces of it, too. For example, there's a lot of focus on wellness programs. There are incentives for employees to be involved in wellness programs as part of the insurance exchange business, and they're incentivized to do it. Well, so you get fit, and you get more out of getting fit. And I think they're going to try an experiment to make patients take on more responsibility for their own health to the extent we can control it. That's probably a good thing. And Republicans should like that idea because it's personal responsibility.
Yeah, yeah.
Not an unattractive idea.
A footnote to that, though, is the same question about aging in general. So if I really take care of myself, wish I had. If I really, it's too late to worry about. If I really take care of myself and I escape all of these slings and arrows and I really get on into my 80s and 90s and is that really a good thing? Because my quality of life is going to deteriorate, and it's very personal. Can the country afford to have a bunch of 90-year-olds? It's not necessarily productive. It draws down on the federal resources. I'm not sure it does anything except it's a moral question, of course. But if we just kick the can down the road, are we really achieving anything?
Well, you're assuming that you just gradually decay and are drawing down the healthcare credit card all the time once you hit your 80s. And there's a point when you become a fragile elderly person, and you start to, quite clearly. But I think there's plenty of evidence that you can stay relatively healthy with exercise and medical attention into your 90s. I had 3 aunts who lived into their hundreds. They were part of a Harvard longevity study.
This is a good thing.
They were passengers on motorcycles. They ate well. They drank.
Really?
They did all the good stuff you had to do to stay healthy.
That's great.
Right.
Well, it's true with modern technology, I consider medicine technology, really.
Well, so for example, if my aunt fell off the motor, she used to go to the Harley convention in Sturgis. She loved the bikies. Into her 90s. If she fell off a motorcycle and broke her hip 20 years ago, you're crippled. And gradually you're going to be infirm and you're in a nursing home and you're going to die fairly quickly. Now you get a hip replacement, even in your 80s, and you're mobile again and you can keep going, and your quality of life is excellent. It's not a bad thing. I think it's something we all aspire to. You live long and well if you can do it.
That's great.
But it does cost more money,
Yeah.
and baby boomers are going to exact a high price out of the healthcare system.
It costs more money. I mean, it's a great thing.
It costs all of us more money.
Yes, well, but here's the thing, is that in your 80s and your 90s, and it costs more money, and you live longer, and you have an extended quality of life. Fabulous on a personal level, and fabulous sort of as the way the civilization evolves.
Right.
However, the guys who pay for that are the young ones who are productive, because by definition, you're not all that productive in your 80s and 90s.
Right.
You're not contributing to the gross product or anything like that.
So that's the Social Security problem.
Yes.
That's the
Yes.
the paying out of the employment system
Yeah.
instead of out of general taxes.
Which may be a big problem going
It
forward.
may be a big problem, and I think it's a problem intergenerationally, but the added cost we're all facing, no matter how you pay for it, is still a structural problem that we have to deal with. So the question is, how can we start reducing the long-term costs of this healthcare? I wish there was an easy answer.
Well,
I can't say to older people, just stop demanding healthcare and die peacefully. I mean, nobody dies peacefully.
that's not moral.
It's not moral, and it's not acceptable.
yeah.
So we have to face Zeke Emanuel, who's now the provost at the University of Pennsylvania and was Obama's go-to health guy, says there's 25% of our healthcare is waste. He has a fantasy that we can cut all the waste out. The problem is, where is the waste? One doctor thinks what's wasteful, that this is wasteful. The other doctor says that may save one of my 10 patients who has this cancer condition. And so waste is hard to define. It always has been. But maybe he's right. Maybe waste will save us. We'll postpone some of these decisions.
Did you see this
Cut the
thing
waste.
in the Times about a fellow named Berwick?
Yes, Don
And
Berwick.
Right. He estimated that the waste in Medicare and Medicaid was something like 150 to 250 billion dollars a year. And of course, he's out of a job right now.
He is, because he once said the British system was a good system. It
can't
is a
say
good
that.
system. You just apparently can't say that. That's American exceptionalism again. You can't point to another country. He is really one of the great scholars, and he's a pediatrician. He's a doctor, but he's one of the great scholars of American healthcare delivery, and the waste that's involved and the way it's financed generates a lot of waste, and too many tests are done. And he's probably right if you can figure out a way to mobilize doctors to try to reduce waste. The payment system doesn't allow that easily. Cardiologists do things they probably shouldn't do because they get paid by procedure. That needs to change. And one of the things the Affordable Care Act does that nobody really talks about is it's got a huge focus on coordinating healthcare. Lots of models that are offered up, like accountable care organizations, where doctors become part of a web of connections, and they get to keep money they save. They get to keep the waste and add it to their own income.
Incentivization.
It's good incentives
Yeah.
if they can make it happen.
One of
And this is all in the works. A lot of hospitals and physician groups are trying to figure out how to create these organizations, and they're ready to accept being no longer an entrepreneurial doctor, but part of the Mayo model or the Cleveland Clinic model of a team effort, where you have to coordinate.
Yeah, the team, it's not so clear that we have teams these days.
I don't think we do have teams, except in the
in the movies.
And the glamour models, which is Mayo. We have the healthcare systems that are glamorous because they work. They all each have long histories, and I don't think you can come to Hawaii and say, let's create a Mayo Clinic. You've got to deal with the existing motivation of doctors and incentivize them to want to become a Mayo Clinic kind of doctor.
So, do you think teams, I don't know if teams are, specifically incentivized in the Act, but do you think teams are one of the solutions? What are the solutions that emerge these days when you look at it? What are the things we should follow as ways to ameliorate the problem?
A lot more coordination between primary care doctors. We need more primary care doctors, we need more nurses, and then we need coordination between all of these people and specialists. So they're all linked by electronic medical records. They all talk about the patient. They develop a case management approach. And so the Act has not only accountable care organizations, but medical homes, other ways in which care is bundled to link all the doctors to come up with a treatment plan and to avoid waste and errors. Double prescribing, making mistakes because patients run from one doctor to another. It's a very chaotic system, very fragmented.
So how do you improve the coordination? For example, in some places, and in Hawaii to some extent, you really can't get to a specialist without going through a primary care. Is that the right way?
That's the managed care model, where the primary care doctor is the gatekeeper and makes a decision as to specialists. And it's not a bad idea.
Theoretically, he's coordinating everything.
He's coordinating. He looks at you and he says, I can't quite manage this. I'm worried about it. You need to see a specialist. If you can run to every specialist when you diagnose yourself, that's, of course, not a good idea.
And it's dangerous for the specialist, too.
Yeah, and it's going to inflate the costs no matter what.
Yeah.
I think that's the idea. You have somebody who's a gatekeeper, somebody who coordinates, somebody who manages. The manager may be different from the gatekeeper. And the greatest costs in the system aren't just the elderly. They're the people who have chronic diseases, they're diabetics, and they need to be managed and monitored. Or they're people who take Coumadin for heart disease. Very complex medications, lots of side effects. That needs to be managed. So hospitals increasingly are hiring hospitalists to manage care in the hospital. I'm not sure that's quite enough. You need somebody to manage the patient, look at diet, lifestyle. It's the model of the sole doctor, the entrepreneurial doctor, seems to me is going to fade.
Yes.
Doctors are going to become parts of large hospital groups. They may become employees or something else.
Yes.
They're not going to have the independence,
We talked about that this
but
week.
they're going to be teamed up.
It seemed clear.
Right.
I've heard, not recently, but I've heard that there are doctors around who drop out of the system and become like independent consultants. And you have a problem, serious problem. Everybody's telling you that you have to make choices, and they don't help you in suggesting choices to you. So you go to this doctor who's a kind of consultant, a coach, if you will, and he helps you make the choices. He gives you instructions on how to deal with the system.
Yeah.
And it sounds like a really great thing. It's personal.
You're paying him like you'd pay a lawyer or somebody
Exactly.
to manage your estate.
Exactly. And,
Right.
and he tells you where the soft points are, where this works, that works. Don't go to this hospital.
That's a
go-
chronic disease model, it seems to me.
Is that what it is? Okay.
That's where you have something that's ongoing and you've got to manage the disease, whatever it is, whether it's Crohn's or something else, and it's going to have a lot of
It's not
pieces to
covered
it.
by insurance. It's just a coach.
Yeah.
I mean, you wonder if you had
not a bad
unlimited
idea.
funds, it might be a good idea to have somebody knowledgeable like that give you the right play.
No, I think you could have a patient advocate who was a nurse who could do a lot of this. I mean, it takes somebody who knows the system and is sophisticated enough to know where you send someone. You don't have to necessarily be a doctor to do that. Doctors know more, and if it's a really complicated disease, it makes sense.
So, does that kind of approach save money? Do you think for the system?
Probably if you have someone who really. This sounds like a guy who gives you advice and then you leave him alone. I think you want somebody who's always involved with your care, who has some skin in the game.
Yes.
Is managing it, and
Yes.
maybe gets a bonus if you live longer and healthier. I mean, it's America. We like incentives, and the Affordable Care Act is built on incentives. Republicans ought to love it. It's a very incentive-driven concept of healthcare, and probably makes sense given our current layout of doctors and incentive systems.
We can't do worse.
We can't do worse, I think. Right.
Now, I want to tell you about what I considered the elephant in the room at this program, and it was all about Kaiser. Because Kaiser has a prevention model, and Kaiser has a different way of organizing.
And I saw the big
primary-
Kaiser facility when I was out driving yesterday.
Yeah,
Yeah.
Well, they got a number of hospitals
Right.
here. They're a successful operation in the face of a lot of unsuccessful operation. We have two hospitals in bankruptcy right now.
And they're both Catholic, are they? One is Catholic.
Yeah. They were both charity hospitals
Yeah,
originally.
the charity hospitals are under a lot of stress
Yeah.
because they don't get the cream of the crop. They get the Medicaid, Medicare population, and the reimbursement's low.
Yeah.
They're really stressed.
Yeah. Well, the government could fix that, couldn't it?
They could increase reimbursement, which doesn't do cost inflation any good. So you're kind of in a double bind no matter what you do. It's a bind. I think these hospitals, I mean, I can tell you what the Catholic systems are doing. They're merging. They're concentrating. They're acting like economists, and they're looking at market share, and they're trying to get more market share. They're not being the little charity markets anymore. Because I think even the Catholic model was built on access to care for the poor. That was why the nuns started lots of hospitals and so on. And if the Affordable Care Act increases access to health care through existing programs, you don't need them as much. They may wither and die in the face of expanding government-funded coverage. So it's not a bad thing in some ways.
So back to
That's a
Kaiser.
piece of history I'm predicting.
There's so many. I mean, I really love this discussion, by the way. So Kaiser prevention.
Right.
Kaiser, they sort of take the coach mentality, and your primary care person really follows you. People talk about the joy of being able to call up their doctor or send email to their doctor and get answers 24/7. That doesn't happen outside Kaiser, not
Right.
here anyway.
Right.
And having the comfort of knowing there's somebody really following you, and having a database that's all through the Kaiser system,
Right.
where they actually share their medical
So
information.
they know things because they have enough patients.
Yeah, it's critical mass.
They insure a lot of California. They have a lot of insurance, a lot of data points
Yeah.
to follow things.
I mean, years ago, maybe they weren't your
Right.
chosen choice, but now they are. A lot of people are going to them, I find, and I think they're taking up the mantle. They really are doing well.
And I know a few Kaiser doctors in California who are generally very satisfied. I mean, they're now really on salary. They're not making money selling services. They're very satisfied with the kind of practice they've got.
Yeah.
A lot of the stress is removed and they get to just give patient care.
Yeah, that's one of the points that one of the physicians, this is interesting, it goes to your point a minute ago, one of the solo private physicians we had in this panel, she said, I'm spending so much time on administration and dealing with carriers and this and that, I don't have the sweet spot time with my patients. This is why I went to medical school. I don't have that, and it's not sustainable for me. I've got to get into a situation, maybe like Kaiser, where I can not have to worry about forms and paper and administration.
Right.
So this has got to be a thing that would benefit everybody going forward.
I think that's right, and I think the integration of electronic medical records is the dream. The problem is, of course, there are different vendors in every hospital system. They use a different vendor, so there's no interoperability. They don't talk to each other. So if you go to France or Canada, you got a card with a chip on it. You plug it in, you're good to go. The system picks it up, and it's like a Visa card. Everything's picked up. It's all integrated. If Visa can do it, it would be nice if we could do it on a national basis. So the French do it, the English do it, the Canadians do it. But
what a shame.
Because we have such a for-profit model,
Yeah.
even with the press of $1 billion in spending for medical records, a lot of them aren't going to talk to each other. And the feds are pushing very hard on interoperability.
Well,
It's a big word.
Can't they command it? Can't they, say you got to do that?
Yeah, but the whole federal approach to healthcare has always been kind of soft regulation and controlling by increasing the use of money. And that's stepping up fast. Pay for performance is a big piece of it. And I think they're going to get more and more, the carrot is getting more and more threatening. We're going to bonus you and we're going to ding you if you don't follow the rules. That's going to start changing things fast because hospitals are the average hospital makes maybe from 0.5 to 3% profit or excess of revenue over income.
Sounds like some grocery store.
It's not much money. It's a tough business.
Yeah.
And if they can get more efficient, they'd be well advised to get more efficient.
Yeah. Well, gee, you don't paint a really optimistic picture. I mean, what is your expectation? Putting, everything in the basket. What is your expectation for the next 5 years?
Okay, so let's make an assumption. The Supreme Court looks at the tax on the act, on the mandate, insurance mandate, and on Medicaid, and says it's a split decision, but they say they're constitutional. Everything in the act is constitutional. So the Republicans have to go away and come up with a new strategy.
Do you predict that?
Oh, of course. I mean, anything to win, no matter what happens to the public. And the number of deaths that will result from a change in the act and denial of coverage is going to be, you could count them in the tens of thousands. There are costs because the act is intended to increase coverage by 32 million, and that's no small thing. People who otherwise didn't have access are going to get it, and they're going to enjoy it. And it's going to save them from a condition that will kill them. So here's what I predict. I think the Supreme Court will say the act is constitutional by a close vote. I think that the insurance companies will adapt and the insurance exchanges will work. Small employers, well, they're suing. Behind closed doors, they really hope that it isn't unconstitutional because they like the fact that they can now have some kind of insurance option and their employees can get insurance and they can recruit. Because it's hard to recruit. If you can't offer insurance, you can't afford it. And the premiums are too high. This kind of levels the playing field for the small companies, and that's where America is supposed to be entrepreneurial. Let's build more small companies. I think the insurance companies adapt and the premiums they'll stabilize. They will continue to rise because insurance companies know how to game the system very well. I think the Medicaid piece of it is always going to be a struggle because you have to get doctors. You're going to have nurses accepted in lieu of doctors to give Medicaid care. It's going to have to be a systematic loosening of medical license restrictions. That's a difficult fight. Doctors are very jealous about their prerogatives, and they actually hate nurses when it comes to this kind of fight. Doctors and nurses don't like each other over turf. But I think there's going to be enough pushing on that nurses will take on a larger role. That's a good thing, too, I think, in my judgment. I mean, you may not want a nurse doing a bypass surgery on you, but you want her to give you lower level care. And I think all the coordination, demonstration projects, and regulations in the Act are going to play out. It's not clear what the secondary effects are, what the collateral damage will be. I think doctors will cease to be independent. They'll become much more staff employees, more and more. They'll lose some of that autonomy, but they may be happier. They won't make as much money. They won't have to deal with insurance companies as much, and they'll be more integrated into the system. And wellness programs probably will work out okay. Probably will have more employees incentivized to work out, go to clubs. It's probably a good thing. I think on balance, the act is a gift. It's complicated. It's hard to sell it because of all the pieces. And it's because of American politics. It's so damn complicated, it seems to me. But it expands coverage. It was all about access. It was only secondarily about cost. And it was third hand about patient quality. There are a lot of provisions that deal with trying to improve quality in hospitals, because we have a lot of casualties in hospitals. Maybe 200,000 or 300,000 deaths a year that are unnecessary.
Wow.
Maybe more. Just in the Medicare population.
Wow.
These are patients who die who didn't have to die.
Wow.
Somebody screwed up a dose. Somebody didn't give an aspirin when they entered the hospital. Simple things. So I'm optimistic it'll make a difference. Is it still a messy system? Very much so. But I
Will
don't
there
think
be
we're ever
amendments? You anticipate amendments?
That depends on who wins the White House and who wins the Senate. I mean, that's the question. I mean, what you don't see so much in these over noisy debates about legislation, healthcare in particular is done by regulation, by sort of behind the scenes rules, guidelines, the moving of money around. It isn't by congressional action. So a lot of what happens will continue to happen, whatever Congress does, whatever the Supreme Court does. It just is, this is the tendency to integrate, to coordinate, to do evidence-based, to do electronic. I mean, there are a lot of good people in the government, believe it or not, who are really trying to make the system work more like the French system, more efficient, more coordinated. That's my hope, that in spite of the worst case scenario, a lot of this will continue forward. And in the case of the best case, it'll move a little faster. So I'm optimistic.
What about Hawaii? You know, Hawaii was early in the game. We had some very progressive laws, very wide, broad-based
Right.
community access to healthcare. Now, we're under stress too.
Right.
We haven't done that well in recent years. The same problems that exist on the national front exist with us. How is it going to affect us? I mean, if it's going to affect us in any different way.
Well, you have access to some of the same federal monies. I mean, presumably people in Hawaii are also seeking out the subsidies for electronic medical records. They're looking at accountable care organizations. They're looking at the models to see if they can take advantage of what is all about the money that comes to you if you adopt a model and you have shared savings. It's all about the money, all running through the act. And the Medicaid expansion should make a difference, depending on the politics of Medicaid in this state.
Yeah.
And that I don't know much about.
What about the homeless? What about the people who really have no money? Are they going to be covered by the act? Are they going to now have a new access?
Well, there's always the hospital emergency room, which is a terribly inefficient way to
model,
do it.
yeah,
I mean, there is language in the act that pushes further the development of the clinical model, so there could be public clinics. And it's already happening in the private market. You see the urgent care centers and drugstores and so on. I actually went to one 2 weeks ago. You could go and have a test for strep throat. And, the nurse was running it, and, it was quick and easy, and your doctor
efficient,
was
yeah.
not around on the weekend. So I think both the private market is responding to some level of care. And then, my guess is there'll be more clinics that are either state or federally funded to deal with the homeless and special populations. And that, unfortunately, that's an area where the religious hospitals often excel. The Catholic hospitals often spend a lot of energy on outpatient facilities for the homeless, for the drug abusers, for single mothers. I'd hate to see that go away.
Yeah.
But that's not part of the act. That's just part of the environment.
You have to count on them still being
We have to hope they're still there.
philanthropic and generous.
Right.
The other thing I wanted to ask you is, this taking it a step further in a sort of a larger context. So right now, we can compare, as never before, the systems in various countries and continents, and we can actually evaluate which ones do better and which ones don't.
We can.
Isn't it likely going forward? I mean, or shouldn't it be likely? Shouldn't it be likely going forward that one system, or maybe a composite of systems, will emerge as a global model, and that countries will start copying each other?
I think they already do. The problem with that is that, I mean, the World Health Organization did a report in 2000 called Health 2000, which compared all the countries. And if you remember the results of that study, France was first, the US was 39th. And we were 39th. It was a complicated metric, and one could argue with the metric, but we were 39th primarily because of access problems and mortality, morbidity rates for minorities. France was right up there because the French live long and prosper. And by every indicator, they had good access. And it made Washington policymakers nervous. This is the first of the serious comparative studies. It's only going to get worse. We're only going to have more and more with better and better data. And we're going to embarrass ourselves unless we get competitive and try to bring ourselves up to the French.
It is embarrassing.
It's embarrassing. It's embarrassing. You travel in Europe and people say, how do you put up with such a lousy system? And they don't know that the best care is great. If you're an upper level professional, you can get great cardiac care or whatever you want.
Yeah.
You've got good insurance.
Yeah.
So
Anyway, I wanted to ask you one last question, Barry.
okay.
Given all these changes, we live in a world of change. There's a whirlpool of change. And there are certain, risks. There are certain, footfalls here for the individual human person in the U.S. and in Hawaii. What's your advice? Not necessarily in terms of the short strokes, but in terms of the approach, that we have in dealing with the system. What should my mindset be in dealing with the system as it is changing?
I haven't talked about parts of the act, but I'll tell you how it all plays out. You need to be smart enough to own your own health and your own ailments, and you can shop. I mean, there is now hospital compare, nursing home compare, physician compare, which is the new model, infection compare. So if you want to go to a hospital, you can ask your doctor, and that's always a great source, but you can also look on websites and say, oh, look, the local hospital has a terrible infection rate, and I'm getting old and I'm vulnerable to infections. The other hospital is half that infection rate. I'm going to start shifting I'm going to talk to my doctor about going to the other place.
Well, there's nobody who cares as much about your life as you do.
That's right.
Thank you, Barry.
Thank you.
A great discussion.